This is Chat Night Africa Live. This is Chat Night Africa Live, about to begin. Chat Night Africa Live from Washington, D.C. metropolitan area. Chat Night Africa Live. Matters that matter. I'm coming back. This is your host, Divine Chamukong. This is Chat Night Africa Live, about to begin.
We're gonna get down. We're gonna get down. We're gonna dance.
Production directors Emmanuel Wayindi and John Tanto Matfire. On Chat Night Africa today, one of the best and brightest in the United States, Dr Ivo Ditah, connecting live from Minnesota. I'm coming back right now. This is Chat Night Africa Live.
We're gonna dance. We're gonna dance. We're gonna party. Party hardy. We're gonna boogie. Boogie woogie. We're gonna dance.
This is Chat Night Africa.
This song right here is dynamite.
This is Chat Night Africa Live.
I'm coming.
Thank you for joining us. Tag, invite your friends, share, because we have life-saving information on Chat Night Africa today.
I'm dancing. I'm ready. I'm coming. We're gonna dance. We're gonna dance. I'm coming back.
I'm coming back.
I'm coming back. I'm coming. We're coming to get down. I'm coming to dance.
Hello. Once again, thank you for joining us today. We have an interesting broadcast for you today. And I say interesting, not just using words to describe it. I say interesting and jaunty, relevant, because if you have a stomach, then you should listen to this broadcast. We will be talking about things that you wouldn't believe are just giving so many people, a lot of headache. Now, if you are ready, I want to inform you that we have a special guest, but before that guest comes in, get the song by artists with one voice.
Calling on the whole world to see men, women, and children of greatness gone down too soon.
This is Artists with One Voice, led by Peter Ngutayong. Immediately after this song, we will be connecting with one of the best medical doctors in the United States, Dr. Ivo Ditah.
Raging so hard in West Africa, women and children dying. See the strong man wiped away in West Africa. Ebola was silent killer.
You are listening to Ebola song by Artists with One Voice.
Women and children dying. See the strong man wiped away.
If you have a stomach, you ought to pay attention to this broadcast.
Sitting by the ocean shore, looking across the waters, is all hope gone? No.
No, we can overcome.
And invite your friend Shetag.
To lend a hand of love.
We have a lot of information for you, because information is power. We come to weaponize you with good information.
No more tears to cry.
This is Chat Night Africa Live, and your host is Divine Chamukong.
Is a painful road. Don't step aside. Hear a cry. Feel a
Was silent killer.
Thank you, Francois Massivinois, Valikul Formiam for tagging, sharing, inviting your friends. Yvonne Pele Mesombe. This is Chat Night Africa. In just a moment, we travel to Minneapolis, Minnesota. He is one of the best medical doctors in the United States. Wait and watch, listen to what's coming on. The taste of the pudding is in the mouth. For now, you are listening to artists with one voice, led by Tayong Peter.
Jangaruju me bonite ko ibola imalon jangaruju bale dindi nye fala mobaye fala biwo sungru nye fala.
And Dr. Ditah, you may begin to send your request to join. Big brother Sami Arembi, greetings from Maryland. This is Chat Night Africa. If you have a stomach, you better listen to this broadcast. Send me a thumbs up if the quality of sound and image is okay. Thank you, thank you. Merci à tout le monde. After this song, we will be taking you over to Minnesota, where we meet one of the brightest medical doctors in the United States of African descent. That's Dr. Ivo Ditah. If you have a stomach, this broadcast concerns you. Get ready with your questions for Dr. Ivo Ditah. Hello once again. Thank you for joining this week's edition of the program Chat Night Africa Live. I'm your host in Washington, D.C. metropolitan area, Divine Chamukong. In the United States, when after consulting your doctor and lab work done, the nurse calls you on the phone, and instead of reading to you your prescriptions or directing you to a pharmacy to get your medication, she's asking you to come in and sit down with your doctor, you can expect that you're not going to get good news. Usually, the news is devastating. Cancer is the last thing anyone wants to be diagnosed with, and for good reasons. Most times, by the time clinical symptoms are detected, it's too late. We are talking about stage 3 or even stage 4. Yes, stage 4 or stage 3 cancer. This strikes panic in families. Now, if you have a stomach, you can have stomach cancer. That's why, again, I repeat, the content of this broadcast concerns you. Ladies and gentlemen, I'm about to take you all to Minneapolis, in the great state of Minnesota, where we have Dr. Ivo Ditah, one of the best in the United States. But don't take my word for it. The taste of the pudding is in the mouth. Hang on. Dr. Ditah, I'm about to take you on the platform. Chat Night Africa Live. And please, if you have any questions related to stomach cancer, get ready to them. That's my friend, Dr. Ditah. Hello, doctor.
Hello, sir. Divine. Good evening. And once more, thank you for inviting me to the program.
Tell me a little bit about Minnesota today. Still very cold?
Oh no, we're having a wonderful summer so far. I mean, the past week has been great. We've had temperatures as high as to the 90s. So it's been a wonderful time. We're having a good time here.
I want to thank you, first of all, Dr. Ditah, for accepting to come on Chat Night Africa. Each time we come knocking, you are available. We are very grateful to you.
Well, Divine, I think this is a very important broadcast. And what you're doing a wonderful job. You don't know how many lives you're touching. You don't know how many lives you're changing. So it's my honor to always come on here and try to share a little bit of my knowledge with your audience and hopefully help somebody somewhere, especially back in Africa.
And ladies and gentlemen, you online watching, if you want to touch somebody with the content of this broadcast, please share, tag, and invite your friends. Information is power, and we come here on Chat Night Africa to weaponize you with the things you need to know. Dr. Ditah, first question. Usually, when somebody is diagnosed with any form of cancer, that strikes panic. Why is that so?
Well, I mean, you're right that each time somebody is diagnosed with cancer, it's really a big issue because we know cancer is something we see more often towards the end of life. It's almost like as our tissues get older, you know, they get out of control. So typically people associate cancer with this is the end. And knowing fully well that the therapeutic or the treatment options that we have for cancer are often not curative, especially when you've had advanced disease. For example, you mentioned stage 3 and 4 disease. At that point, in most cancers, there's very little that can be done to actually cure you. So cancer, if you're diagnosed early, it's good news. If you're diagnosed late, it's often not very good news. And because people know, a lot of people are older people, all die mostly from cancers. That's what kills them. So I'm certainly not surprised that each time someone is diagnosed with stomach or with any other cancer, they get really very worried because they don't know what lies ahead. And even when, they have to go on and receive the kind of therapies that we have available today, those things come with a lot of side effects, and which can often affect the quality of life so much that people are really scared, and that's very understandable.
Dr. Ditah, tell these people watching why they should be concerned about stomach cancer, which is our focus of today on the show. Why should these people watching be concerned?
Well, because we all have a stomach. Yeah, stomach cancer is one of those cancers that doesn't get the attention that it deserves. But as an African, I think we Africans need to really pay attention to stomach cancer, because one of the main established risk factors for stomach cancer is very prevalent or common among African descendants. Whether you've left Africa and come over here, unfortunately, you carry this baggage that we had early on in childhood along with you wherever you're going to. So, especially Africans, this is a very important topic. People that live in the far East Asia, this is a very important topic. In the United States, again, not a very common cancer, but as people are getting older and older, as we're getting better with medical technology, and people are living longer and longer, we're beginning to see quite a good number of stomach cancer, even among non-Hispanic whites.
Some of the cancers that we hear very often about include, but not limited to, brain cancer, lung cancer, liver, prostate, cervical cancer, pancreatic cancer, blood cancer, bone cancer. Dr. Ditah, does it mean just about any part of the human body? is vulnerable to cancer. Why the plethora of cancers?
Well, yes, to answer your question, every part of the body can develop cancer, whether it's your mouth, whether it's your nose, whether it's your eye, whether it's your ear, your skin. Every single part of your body can develop cancer. And you ask the question, why are we hearing too much about cancers? Again, as I said in my introduction, because we are living longer. Unfortunately, with improvements in medical technology, we're excited that we are having longer, people are living longer into their hundreds. But that also comes at a price that we are seeing a lot of the things that are often seen in tissue, in people that are older. So that's why cancer is becoming a major problem. And when you live in a society like a developed society where infections are no longer the problem, feeding, food is not longer the problem, they are more likely to develop chronic diseases related to excesses, including an increase in the number of years that people are living. We see obesity. Why? Because of excesses. The food. You go to Africa, somebody goes to bed thinking, am I going to have food tomorrow? In America, people are asking, am I going to have how many servings of this? How many? Whereas in Africa, people are asking themselves whether they're going to have food. So in a developed society, we deal more with chronic, non-communicable diseases such as cancer, diabetes, hypertension, whereas the leading cause of mortality in Africans relates mostly to infections, diseases of poverty. That's how I put it.
Let me ask you this question before we get into the nooks, into the marrow of the subject, stomach cancer. We don't hear, do you have the impression that people just avoid the subject? Because you know how terrible it could sound when you hear somebody, a friend, is diagnosed with cancer.
Oh, yeah, it's very scary. I'm not surprised a lot. I mean, personally, I've lost a lot of friends, close family members to cancer. One story comes to mind. Again, I'm not going to mention names here or try to give any information that will lead to you identifying my people. But in the past 1 year or so, I've lost at least 4 to 5 very close family friends to cancer. So it's common. And I'm an endoscopist. I do upper endoscopy, so I've diagnosed quite a handful of stomach cancers, not to talk about colon cancers. I myself, in fact, when I am doing my procedure and I see it, I kind of get this chill down my spine that, oh my God, this is a cancer. Why? Because I know what comes next. It's often a very difficult time, not only for the patient and their family, but the road ahead is often very, very tedious. So it's scary. And as we mentioned before, it's one of the things that people die from. In the United States, a lot of people, how do they die? They die from this kind of stuff. So it's often a very scary topic to hold with your patient. But to hone in on stomach cancer, we know that worldwide, actually, we know that stomach cancer is the second leading cause of cancer deaths in the whole world. In the United States, stomach cancer is the number 14th cause of cancer deaths. That's, remember I said, in the United States, it's mostly an issue with immigrants, especially from Far East Asia and those from Africa. But the indigenous people here, the people that were born here, are at a lower risk of developing stomach cancer. And as we mentioned, there's a lot of geographic variation in the incidence or prevalence of stomach cancer. So again, I know we will get to these questions. I don't want to run too far ahead, but
right.
I think that's
you may want to adjust yourself on your camera because we are seeing barely above your nose. So you may want to adjust yourself on your camera. Your looks a lot beautiful, perfect. Now, the other question I want to ask you, Doctor, is when people hear somebody has any form of cancer, I'll give you an example. Lung cancer, the first question is, was he smoking? So when we talk about stomach cancer, is this something somebody does or doesn't do or did or didn't do that resulted in him developing stomach cancer?
Yeah, I think that's a very important question, because when I come on here, my main focus is to provide information on things that you can change or things that you can do to mitigate your risk of developing any form of cancer. So with that question, I think I will move into discussing the risk factors for stomach cancer, and also discuss some of the controversial factors that people think are protective against stomach cancer. Let's start with the bad ones by talking about the main risk factors. So one of the main risk factors for stomach cancer, maybe a step back just to say, first of all, there are several different types of stomach cancers. A majority, we're talking of 90 to 95%, which is what I'll be talking about here tonight, is called adenocarcinomas of the stomach. The other forms of stomach cancers include things like gastric lymphomas, neuroendocrine tumors of the stomach, which I don't want you to really pay too much attention to. That constitutes just about 5% of all the stomach cancers that we know worldwide. So we are talking, this topic today is basically focusing on what we call gastric adenocarcinomas. And these are the ones that have the very bad prognostic, meaning outcomes. So to talk about the risk factors, the number one and biggest risk factor for stomach cancer is due to a bacteria. And that bacteria is called Helicobacter pylori. I'm sure a lot of us have heard about HPI or H. pylori infection. That is the bacteria that has been tied, meaning there is a cause and effect relationship between having that bacterial infection and developing stomach cancer. Now, I did not say every person with H. pylori infection will develop stomach cancer. No, I said people that if you have H. pylori infection that becomes chronic, we know that that can cause you stomach cancer. And why is this very important to your audience, which I know is predominantly of African origin? H. pylori infection is very common among Africans. It's a disease, as I'll put it again, of poverty. Where there is poverty, where there is poor hygiene, H. pylori infection is very common. I cited Africa, excluding North Africa. We actually know that North Africa doesn't have a high prevalence. But anywhere in the south of Africa, excluding Egypt and all those countries up there, Far East Asia, they have a very high prevalence of H. pylori infection. So if there was one thing that we can do, is to identify people that have H. pylori infection. Unfortunately, we don't have any screening programs for H. pylori infection. The only screening program that we know is actually based in Japan. It's only in Japan where they have national guidelines that permit or that dictate that people need to be screened for stomach cancer, because they do also have the highest prevalence or the highest incidence of stomach cancer. So, but for Africa, of course, even the most common cancers we don't screen for. What more about H. pylori infection? And as I mentioned, it's a bacteria. And when we screen patients, I've had H. pylori infection, and I've had to be treated. So when we identify it, the good news is that it's a bacteria. We use a combination of antibiotics and what we call antiacid medications, and we can completely eradicate the infection. Personally, I tell all my friends, again, this is not written in any textbook, who come from Africa, all my friends of African descent, I have personally asked them to get screen for H. pylori infection. Especially those that have, and the symptoms, you just get a discomfort in your stomach or just below your chest, in the upper part of your abdomen, the area that we call the epigastric area, just below your chest bone. And if you're African descent, you see me in my clinic, you have anything to do with that, I am screening you immediately for H. pylori infection. So again, I'm talking a lot about H. pylori infection primarily because it is one of the only factors that has been shown to have a cause and effect relationship with gastric cancer. The good news is that if you get screened and if you get tested for H. pylori infection and you are positive, we can eradicate the infection. It's a treatment for that with a duration that goes from 10 to 14 days. But that's nothing compared to you developing stomach cancer. So with that, I'll move into the other risk factors. The second one of which, I don't want to use a lot of medical terms here. The second thing I will talk about, I'm sorry, somebody was calling. I just put them off. Hopefully they don't call again. The second factor will be smoking. As you know, smoking is becoming a habit. Again, we've seen a real decrease in the number of people that smoke in the Western world. But as you know, a lot of the people that migrate to this country are picking up smoking. Again, the bottom line is we know that smoking is a risk factor. It is not as strong a factor like what I described before, which is the H. pylori infection that has a cause-effect relationship. But smoking has often, people that develop gastric cancer, a good proportion of them are known to be smokers. And so smoking is associated with the development of gastric cancer. It's not causal. It's not causal, but we know because we haven't understood the mechanism. Just like for lung cancer, we understand the mechanism by which smoking causes lung cancer. So we say there is a cause effect. But for the stomach, we don't have that kind of a mechanism. But we know that people who smoke, among people that have gastric cancer, a majority of them are smokers. So that's what we mean by an association. Now, the other factors that we have is hereditary. These are hereditary factors. So in a family that has a strong history of stomach cancers, people that come from such a family are at an increased risk of developing gastric cancer. And that information you often gather from talking to the patient, asking about their family history. And in those patients, there is actually an argument whether we should go ahead and screen them for gastric cancer. If not, at the very least, make sure that they don't have H. pylori infection. And if they have it, you eradicate it. So those factors I described, there are a few more. I don't want to talk about them because they are too medical. And they are mostly based on us doing an endoscopy and finding things in the stomach. I can cite a few, what we call intestinal metaplasia, where your stomach looks more like your intestines. Again, I don't want to go into that because you cannot modify those factors. I prefer to focus on factors that our audience, that you can do something about, not things that you really cannot change too much. We also know that patients that carry hereditary cancer syndromes are also at risk of stomach cancer. There are a lot of colon cancer syndromes. One of them we call familial adenomatosis polyposis syndrome. The other one we call a hereditary non-polyposis colorectal cancer syndrome. Again, these are big terms, but we know that when we diagnose patients with these syndromes, we will send them for an upper endoscopy because they are at higher risk of developing stomach cancer. I'll leave it at that for the definite factors. Now, there are other factors that have been classified as being probable, that these are probably increase your risk of developing stomach cancer. people have argued that high salt intake may actually put you at an increased risk of developing stomach cancer. That association is not as strong as the other factors, but we do know that that's something that is out there. The other factor is that of people that consume snuff. You know, the kind of snuffing tobacco. People
Yes.
that use that form of tobacco are also known to be at a slightly increased risk of gastric cancer. The other factor I will talk about is obesity. Unfortunately, because obesity is becoming very prevalent and it seems like the whole world is going to have obesity, we're beginning to find all these associations, and we know that patients who are obese are also at an increased risk of gastric, are probably at increased risk for stomach cancer. Now, there may be some protective factors. The first one, I'm sure you've heard about aspirin use and the prevention of stroke, cardiovascular disease is all there on television. They've also found that maybe aspirin could be protective. I'm not saying here that people should start taking aspirin. So what I'm telling you now, it's controversial. But it has been found that perhaps the use of aspirin or other non-steroidal anti-inflammatory medications may actually be protective against stomach cancer. Increased consumption of green tea has also been found that it may be protective against developing stomach cancer. Increased consumption of vegetables, high fiber diets, things that are rich in vitamin C. Vitamin C which is called ascorbic acid, is found in all the yellowy stuff out there, vegetables that we consume, has also been associated, is also put out there as one of the factors that may actually be protective against stomach cancer. We also have people that consume high amounts of fruits. Fruit intake may also be protective. Now, there are some factors that I say they may be possible. So we've discussed definite risk factors. We've spoken about probable risk factors. We've spoken about factors that people are making an argument that are protective. And now some possible risk factors being thrown out there include high alcohol intake. They say maybe it's possible that people that consume a huge amount of alcohol may actually be at risk of stomach cancer. And the last factor I'll talk about is low socioeconomic status. What that means, it's a loaded term. But
I was going to ask you that question.
Yes, I mean, again, poverty. People that come from a poor background, perhaps they don't have access to go even to get medical attention. They may even have symptoms that may be due to H. pylori. They've never been to the hospital. Nobody has tested them, and they end up coming with stomach cancer. So it's a big term that really includes too many factors, but basically you can understand it as people who perhaps live below the poverty line.
Dr. Ditah, before I ask you the question I have now, I am inviting members of the audience to post any questions that they have related to stomach cancer. Again, this is relevant to you watching because, like he said, if you have a stomach, and all of us do have one, then you can have stomach cancer. And there are many types of stomach cancer. Now, Doc, when you are diagnosed with cancer, I want to imagine, I've never been diagnosed with one, thank God, but I can imagine that what runs through the mind of the patient is, did I miss some signs and symptoms? What should really somebody be thinking about? What should make you feel like, oh my God, maybe I should go see Dr. Ditah or any other doctor now? I could be developing stomach cancer. What is it to make you go?
Yeah, a good question. And why I say it's a very good question is because your audience will probably be disappointed to hear that. Uh, Unfortunately, by the time we diagnose stomach cancer, it's often in its advanced stages, meaning it doesn't have a lot of symptoms. You're going about your life, everything is going good until that day when the disease has really grown to a significant advanced stage that you develop one of the symptoms, which I'm going to be describing, and that take you to your physician, and you're found to have disease that we cannot treat. Unfortunately, that's just the way stomach cancer is. So what else? Let's say you're fortunate and you develop symptoms. What are the things that you may experience? Well, as I earlier described, your stomach is just below your chest bone. So the first thing is you may just feel a discomfort, a kind of a nagging pain, which is it's not enough to even take you to your doctor, but that is persistent. You're aware that something is there, but it's not severe enough to take you to your doctor. That's when disease is still localized only in the stomach. The second thing is, depending on where the cancer is located at, you may also have some other kind of symptoms. For example, if the cancer is located at the junction where the stomach is supposed to empty into your small intestines, then you can no longer empty your stomach. Food will stand in your stomach. By the time you take 1 or 2 bites of food, you feel like you're already full. You cannot eat anymore. So what we call early satiety. The plate of food, one of your best meals, they bring it for 2 bites. I'm okay, I can't eat anymore. I feel full in my stomach. That's what you will call, you have gastric outlet obstruction. Now, if this tumor was located higher up in your stomach, at the junction between your esophagus and your stomach, you may have trouble swallowing because it's blocking the entry into the stomach. So when you eat food, you feel like, oh, the food is stuck. It cannot go down. Some people may end up having to bring it out. And then, they may come to the emergency, they may come to the ER that food is stuck. It cannot go. I cannot swallow my secretions. And then we go in, maybe we take out the food, and then we see this mass that's sitting there.
Now, quick question, Doc. At what stage would this cancer be when you start realizing you can't eat your favorite food, you cannot swallow? At what stage would it be at this point, if that's as a result of stomach cancer?
Again, I want you to, I made a statement before I described that these symptoms do not really relate to stage. Why? Because it just depends on where it's located in your stomach. And if it's located at that junction where the stomach connects with your esophagus, well, you will have symptoms pretty early, maybe when the disease is still very early. But just because of where it's located, that's why you have developed those symptoms. And those people are actually fortunate. And then if it's located at the exit of the stomach into the small bowel, you will get obstructed and develop those symptoms I described. It doesn't really matter when, at what stage that disease is. It just happened like that because of its location. So let's continue with the symptoms.
Okay.
Tumors bleed. They have a tendency to bleed. So this may be a patient that show up to the doctor, I'm tired, I'm feeling a bit weak more than I normally usually is. And the doctor does the blood test and he sees that your hemoglobin is low. He says, what happened? He may do other stool tests to see whether are you bleeding in your GI tract. Even most of those patients will end up getting an endoscopy. And sometimes that's how we diagnose it. So they typically have what you call iron deficiency anemia, meaning, and these are patients that have had chronic blood loss. Because it's not a massive bleed. You can have a massive bleed. But typically, these are very minuscule or small bleeds that occur over a long period of time to the point where the patient then becomes symptomatic. And it can take years to get there. Now, just like with every other cancer, some of the symptoms that are not unique to stomach cancer can happen, like wasting or what we describe as abnormal weight loss. And abnormal weight loss is typically defined as you dropping about 5 to 10% of your weight in a period of about 6 months. That will be considered abnormal weight loss. You need to see your doctor if that happened to you. These people typically, they don't have an appetite. The appetite is gone. They feel very tired and exhausted. So, and some of them, they begin to, in very advanced disease, if the disease has spread outside of your stomach, you may get other manifestations depending on where the cancer has gone to. For example, if it has gone to your liver, you may have your liver test may become abnormal or something may happen. Then we do an ultrasound. Hey, we see that there is some tumor somewhere. Then we start to find out where did this come from, and we end up seeing that it came from the stomach. Sometimes it spreads into the coverings of the abdomen called the peritoneum. And people come in with fluid in their belly, or my belly is distended. And when we go in, we take some of the fluid and analyze it. We find out that you've developed that what actually caused it were cancer cells originating from the stomach. Then we go back to your stomach and we find the primary tumor. People can develop lymph nodes. Some of them develop something we call virtual nodes that develop in the neck region up here, just where I'm feeling there's a small cavity there, that in the supracostal notch, the way we describe it, that we can find those nodes inside. You can, so again, there are those symptoms which are non-specific, and some of the symptoms that can point you to something going on in the stomach. Sometimes you're going, but for an ultrasound or a CT scan of your abdomen, and then when they do it, the doctor says, hey, there is something I'm seeing in the stomach. And then we go in, and that's when we find it. So to summarize, Divine, a lot of people with stomach cancer will have no symptoms until when the disease is very advanced. Sometimes you may be lucky, depending on where the tumor is located, to have some symptoms that bring you earlier to your physician, and he does an endoscopy. There are also things that can point us. For example, if you were doing very great and suddenly after the age of 55 or 60, you came in with new onset pain in your lower in your stomach, or some reflux, what we call dyspepsia, because of your age, I will be more inclined to do an upper endoscopy because of your age. Because as I pointed out, cancer is common in older people. And if you have those symptoms at the age of 20 or 25, I will not be doing an upper endoscopy. I'm going to try to treat you with medications that we have out there, and I may only go in to look if you fail to respond to medications. But for an older person, 55, 60, that comes in with those same symptoms, the guidelines say, look, because he is older, he is at higher risk of bad things. You cannot treat him like somebody who is 25 years or 30. So again, those are some of the clinical clues and guidelines that we have to guide us to diagnose stomach cancer.
I want to imagine, Dr. Ditah, by the way, for those of you just joining the broadcast, this is Chat Night Africa Live. My guest today is Dr. Ivo Ditah, connecting from Minnesota, United States. He treats cancer patients almost every minute he is at work. That's why he is the most appropriate person we thought to bring on this show to take your questions. And so if you have questions about stomach cancer, please post the questions, and I'll take the questions right now over to Dr. Ditah. Dr. Ditah, we're talking about stomach cancer today. What makes it that it doesn't stay where it is? It spreads to other areas of the body. That's part A of my question. Part B is what makes the bacterial infection you talked about earlier to mutate into a cancerous situation. And again, why doesn't it stay in the stomach? It spreads to other organs. And which organs are we talking about?
Well, I will start with your second question and to clarify to the audience that I did not say the bacteria moves to other organs. No. The bacteria is typically in your stomach. It causes it's an infection. Infection goes with what we call inflammation. And when a tissue is inflamed or irritated for a very long time, the process of irritation, trying to heal, irritation, trying to heal, can lead to those cells undergoing changes that we call dysplastic changes. It is those kind of changes that can end up progressing into a cancer. And in fact, if I did an upper endoscopy on you and found that you had dysplasia, I'm going to put you, that's one of the groups of people that we have under a surveillance program. That those patients are at so much at risk that we have to monitor them. So any chronic inflammatory state, for example, H. pylori will cause what we call chronic gastritis. Gastritis simply means inflammation of the stomach. Chronic simply means it's been there for a long time. That's a risk factor for cancer. If you look at the parallel, when we talk about the colon, patients that develop what we call inflammatory bowel disease, where their colon is chronically inflamed, their risk of developing colon cancer is at least 8 times that of the general population. Why? Because of the chronic inflammation. That's why when we identify that infection and treat it, we typically take away that factor, which is the chronic inflammatory changes. And we know there are some genetic factors associated with H. pylori. I'm not going to go into them. One of them, we say they are CAG or CAG positive strains of H. pylori, which we know are the most associated with developing that cancer. But that's too much information for the audience at this point. Now, your first question was, why does it spread? This is a cancer. Just like any other cancer, cancer typically starts as a very small lesion. As time goes on, it begins to penetrate, for example, the wall of the stomach. As it penetrates the wall of the stomach, it begins to get to where you have blood vessels. And if it invades a blood vessel, or even if it doesn't invade, but it's in close proximity with a blood vessel, you can imagine one of the cancer cells plugging off and getting into your blood vessel, going into the bloodstream and getting flung anywhere. We know that mostly blood that comes from the stomach, your intestines. The first area that blood stops at is in your liver, which is one of the main reasons why the first areas where cancer goes to, especially cancer of the stomach, is to the liver. So again, to answer your question, typically it starts as a small lesion in your stomach wall. Then as time goes on, it's increasing in size and increasing in depth. And it grows, as it grows into the wall, it gets in close proximity to blood vessels and what we call lymphatics. And once it gets into those lymphatics, you remember blood vessels, they take blood and swindle it throughout the whole body. That cell is going to be thrown anywhere else. And where it settles, it will begin to grow that tumor from that site. That's called metastasis. And if it instead got into your lymphatic system, which is another kind of blood draining system in your body, it typically goes to the lymph nodes. And your lymph nodes, I cited the one up here. There are other lymph nodes around your navel that they can also go to. And a patient comes, oh, I feel this nodule around my navel. Then you start to check the patient out. You find out that they have a tumor in their stomach. So that's usually how cancer spread. That's not unique to stomach cancer. Every cancer, it's never good to say every cancer. Most cancers, that's the mechanism by which they spread to other organs.
Now, when we talk about spreading to the liver, the pancreas, and other organs of the body, are we at this point talking about, for example, liver cancer at the same time that you have stomach cancer, pancreatic cancer at the same time that you have stomach cancer? Or what's the description you doctors give it? Or just say that it's spread?
When you have stage 4 disease, it goes, I mean, when you made the introduction, you spoke about advanced disease stage 3 and stage 4. By the time you have stage 4 disease, it implies that the disease has spread beyond the primary site where it started from. So if you have a tumor cell in your liver, and we find out that that tumor cell, when we look at it we do a biopsy, for example, we can tell that the cells in that tumor are not from the liver. They are stomach cells. What that tells me is that this did not originate in the liver. Something happened in your stomach and then spread to the liver. And there is the medical term, when disease has gone beyond its primary site to another organ, is called metastasis. The cancer has metastasized, meaning it has left its primary site of origin and has spread to another organ in the body. At that point, you can imagine that's very important, because those patients do not stand to benefit from surgery unless they are if they had obstruction. Of course, you can help their quality of life by doing surgery to uplift that obstruction. But if the disease has gone to other organs, you cannot go and cut out those organs. So typically, that's why at that stage of disease, you always hear, this is bad news. Again, there are some cancers that when they've gone, if you have one single lesion in your liver, for example, if you had colon cancer, had one localized area in your liver, and we treat, and we don't have evidence of that cancer being anywhere else, we can take out that cancer in the colon, do surgery on the liver, and just chop out that nodule. And some people can be cured, but that's very rare.
Dr. Ditah, I've seen a lot of cancer patients, some members of my family and some friends. They tend to complain of extreme pain. First question, or part A, what causes the pain? Why are cancer patients suffering from so much pain? Number 2, or part B of my question is, why do they lose a lot of weight? Because, I mean, you can pretty much tell. I've seen people who have prostate cancer, lung cancer, brain cancer. I mean, met them physically, and you can really tell from looking at their physique. Why is that so?
There's not a single answer. It's multifactorial. Now, let's take pain, for example. Cancers are very unique. And even as you can imagine, the reason why we are not able to cure most cancers is because in the medical world, we are very limited in our knowledge, even on cancers. That's why it's still a huge, huge challenge. Cancers are known to produce certain chemicals, some that we don't even know, but we think exist, and cause syndromes that we call paraneoplastic syndromes. Para meaning it's not due to the tumor, it's not the tumor itself, but this tumor is producing certain chemicals that are causing certain kind of manifestation or symptoms that we don't We cannot even explain or know what that chemical is. The name we give to those syndromes are called paraneoplastic syndromes. And one of them, for example, is the pain you're talking about. But remember, a tumor is local. We spoke about invasion. Remember, you have nerves everywhere. If the tumor also invades the nervous supply of that around where it's localized or where it has spread to, those patients can also have a lot of pain. But not to belabor the point, a lot of the syndromes that we observe in cancer are due to chemicals that cause what we call paraneoplastic syndromes. And those syndromes are very difficult to manage. We just try what is available for pain management and hope that one of it works. But they are very challenging. And typically, by the time patients start developing that, you're getting, it's an advanced disease and you're getting towards the end. By the time people start having paraneoplastic syndrome. Other paraneoplastic syndromes are simple. I can check your blood sugar now, it's 200. In 30 minutes, you come in, you're sweaty, they check your blood sugar, it's 15. And you're like, in 30 minutes, in 1 hour? What happened? Nobody knows. It's a paraneoplastic syndrome. And that's how these people die. Imagine your blood sugar went down to 15. Before they get you, you'll probably have died. There are a lot of those syndromes, which we think the tumor, as it gets advanced, produces a lot of chemicals that we cannot even pick up medically that explain a lot of the syndromes. One of them is wasting. Cancer patients, their appetite is all gone. So if you came to me and you had massive weight loss and you told me that your appetite is gone, one of the things I need to rule out until proven otherwise will be that you don't have a cancer. Especially if you're making no effort to drop the weight. You're not exercising, you're not dieting. What I would call, when I teach my fellows, I tell them that if you have unintentional abnormal weight loss with a poor appetite, the first thing we must do is show that you don't have a cancer.
This is Chat Night Africa Live, and my guest today is Dr. Ivo Ditah. He is connecting live from Minnesota. We're talking about stomach cancer, the complications. I know you talked about stomach cancer spreading to other organs. Are there other complications that people should know about? And then we'll go to treatment.
Well, as I said, the complications, for example, if the tumor blocked the entry into your stomach, we have to do something. That's a complication. You have dysphagia, what we call difficulties with swallowing. That has to be addressed. If the stomach blocked your stomach, if the cancer blocked your stomach from emptying, you have gastric outlet obstruction. That would need to be addressed. So typically, Divine, complications of cancers can be seen in 3 different ways. There are what we call local complications, which all relate to the presence of the tumor at that site, locally. The location, is it blocking something? Then you have what we call locoregional complications. For example, if it spreads through the wall of the stomach and the next door organ gets involved, you then have what we call locoregional complications. For example, in stomach cancer, if it spread beyond the wall and touched the other parts of the intestine, you may have a connection between your stomach now and your intestine. That's called a fistula. It will come with its own complications. Then you can have what we call not locoregional anymore, but complications related to distant metastasis. Imagine that tumor went to your brain. It caused a stroke. It goes to your lung. It can block blood supply to the lung. You will have what we call a pulmonary embolus or pulmonary embolism due to a tumor. So cancers, you can typically see their complications in terms of local, meaning where they are they located, what are they doing? Then you look at loco-regional, the organs around them, how are they reacting? How do they relate as this tumor is beginning to spread beyond the stomach? And then you look at distant complications that relate to metastasis. So those things are very important. Another local complication, for example, that tumor can suddenly open up and bleed profusely. It can, as it goes across the wall, it can cause a perforation. And then you come in with peritonitis because the fluid from the stomach has gone into your peritoneal cavity. So complications, if you see it in that format that I just presented, you will be covered.
I can begin to imagine, doctor, that treating cancer patients, it's like dealing with a Sahara desert. I mean, it's a sandstorm of diseases, other complications. Now, that leads me to the treatment. When you find out, when somebody has to be called to your office after lab work, that Dr. Ditah wants to sit down with you, where does the treatment really begin? I know you talked about surgery when it's still possible or needed, but otherwise, what are you treating, considering the myriad, the legion of complications that you have to handle? What are you handling? What are you doing?
The key take-home message here.
And before you answer that question, I want to thank all those who are sharing this broadcast. I can't even begin to imagine the importance of this broadcast. If you have a stomach, if your friends, your relatives have stomachs, they ought to listen to this broadcast. So please share it. Yes, Dr. Ditah.
So just as a general concept in terms of cancer management, it typically starts, the most crucial and determinant factor is the stage of the disease. Early diagnosis is typically goes with forms of treatment that are curative. And late stages of cancer typically go with forms of treatment that are typically not curative. So talking about the different forms of therapy, the first is surgery. That's the best form of treatment that if you are eligible, that you can get, and you are probably cured from your disease. Now, when you spoke, let me just finish the different forms. So you have the surgical treatment. You have what we call chemoradiation, chemotherapy. Beyond chemotherapy, we do what we call chemoradiation therapy. And of course, palliative care. Palliative care. So when a stomach cancer, it can be staged, just like we've been talking, stage 1, stage 2, stage 3, stage 4. Stage 1 means you were diagnosed really early, where the disease is typically still located inside the lining of your stomach. Those patients are the patients that qualify for curative treatment with surgery. You go in, you take out the tumor, they are well. They don't need chemotherapy. They don't need therapy before you take it out, and they are done. Unfortunately, as we pointed out, those patients are not many. In fact, by the time stomach cancer is diagnosed, 33% have cancer in other organs. So 1 out of every 3 people diagnosed with stomach cancer, the cancer will be found in another organ. You can imagine metastatic disease is not for surgical therapy. You can have surgery to take away the mechanical impact, the structural problems that the tumor is causing, but not for curative intent. And as the stages progress to 2, 3, you can imagine the forms of curative, the curative regimen is gone. You are now left with chemotherapy. We've spoken here before about the side effects, the potential implications. And as we mentioned, they are typically not curative. They may give you another few months to a year, but we know what will ultimately happen. And during that period, your quality of life is typically quite poor. So stomach cancer is one of those bad ones. We've spoken about pancreatic cancer. Stomach is very close. Another one is things like the gallbladder cancer, where unfortunately by the time people are diagnosed, 33% have metastasis. It doesn't mean the others do not have spread to their lymph nodes, meaning it's not surgery alone. You will get surgery, but you will need chemotherapy to take care of that disease that has gone there. And there's even a concept today called micrometastasis, meaning we believe that there are some tumor cells located in other organs which are still too small that the technology that we have today cannot pick up. So even though sometimes when they say we don't see disease anywhere else, you can take the case of, for example, melanoma, so breast cancer, where you are treated and for 3-4 years, they are monitoring you and say everything is quiet. Then you wake up one morning, you have a dry cough. You show up to the hospital, they do a CT scan, and they say, oh, we see a tumor in the lung. And they find out that it's breast cancer. And then you are like, 5 years ago, we were cured. Both breasts are gone. Where did this come from now? So there's this concept of micrometastasis, which are cancer cells that might be very small, that the current medical technology or diagnostic procedures that we have are not yet able to pick up. And down the road, when they become sizable or grow to a certain level, they show up with symptoms and we find out that, oh, here we go again. We thought you were cured, but we are sorry you are not.
Miss Okechukwu says Dr. Ditah is one of the brightest gentlemen she has seen. And she further says this is the best show on Facebook that, we could come here and talk about sex and all kinds of stuff, but I think this is what people really need to know. And so if you have friends that have a stomach, if your friends, your family members, your co-workers each carry a stomach, you want to share this broadcast. It's important that this message from Dr. Ditah goes far and wide. Thank you, Nibob Gambuton, for your kind words. Doctor, the other question I wanted to ask you is, does it mean that when a doctor tells you that, well, it's time we put you on chemo regimens, you can just go home and plan your funeral? Has somebody ever survived after chemo?
Yes, I don't want to give the impression here that chemotherapy is a death.
I have to ask that question.
Yeah, it's a death sentence. No. Depending on what cancer you have, there's some cancers that can be cured with chemotherapy. For example, there are certain forms of lymphomas for which we have medications that work very well. There is even a form of stomach cancer that is related to this H. pylori, that when you get diagnosed with, and we eradicate the H. pylori infection, that cancer is gone. That was something we didn't talk about, but there's something called mucosal associated lymphoid tissue. It's a form of cancer, lymphoma, related to H. pylori infection, that when you have, the treatment is actually to treat you for the H. pylori infection, and the cancer gets away. And I also cited other forms of lymphoma, like the non-Hodgkin's, where we know that with treatment, you can get cured. So again, the message here is the earlier you are diagnosed, the better. There are some tumors that are systemic, that like the blood cancers. Those you cannot do any surgery. It's only chemotherapy. And some respond very nicely.
And let's talk about chemotherapy, Dr. Ditah. I met a lady whose husband, somewhere in this country, again, I'm not going to name the state, that way it doesn't get zeroed out on somebody. She said her husband had pancreatic cancer, and if they had to do it all over again, she wasn't sure that chemo would be what she would run for. Why do you think she felt that way?
Well, as we pointed out, chemotherapy is tough on the body.
In terms of what?
You can imagine the mechanism of chemotherapy is there are agents that look for rapidly dividing cells, because tumor cells, by definition, are rapidly dividing. And most chemotherapy is to target rapidly dividing cells and stop some mechanism within them from continuing that process. As a human being, you have rapidly dividing cells everywhere. Chemotherapy is not knowledgeable, it's not a human being to know that this cell that is rapidly dividing is not a tumor, and it is only the cell over here that is rapidly dividing, that's the tumor that I need to attack. So the issue of targeting is a big problem. If we could find those therapies that will target only the tumor and not go to other organs, for example, your intestines, your testes, everywhere where you have your hair, your skin, where cells are constantly dividing, it will be more effective. But unfortunately, these systemic therapies, while they are working on the tumor, are also working everywhere else in your body. These are people whose appetite is almost often gone. They are at risk of other infections. It suppresses your immune system. And any other infection, just like HIV. I mean, for example, if you had hepatitis B and you did not require treatment, if you had to go on chemotherapy, I will have to do something different, because chemotherapy is going to change your whole mechanism, so much so that this infection, the hepatitis B that was quiet, will have the chance to act up because there is nothing to keep him quiet. You see these patients going around, they have mask, because if any person coughs, if there's any infection out there, and you cough into their face, they may acquire it. You see us push them to get every kind of vaccine that is available, so to prevent in case you ever came in contact. They are exhausted. They may develop diarrhea. They may have a cough. So chemotherapy is a systemic form of treatment. Unfortunately, while it's acting on the tumor, it's also acting elsewhere. And tumor cells are very intelligent. Once you start acting on them, they tweak something in their system, and you can no longer get them anymore. And it gets to a point your doc says, you know what, I'm sorry, you're not responding. For this patient you described, unfortunately, pancreatic cancer remains a huge challenge to the medical community. Survival is horrible. I'm sure your guests can go back to the discussion we had here on pancreatic cancer and get more detailed information on
Now, is it
survival and
possible, Dr.
prognosis.
Ditah, is it possible to, don't you guys treating cancers, don't you have some form of targeted treatment that can, maybe you can get from stem cell? I'm sorry, I'm not a doctor like you, but from stem cell, you can actually design some medication for that patient that doesn't destroy the immune system, that doesn't have the massive negative effects, that just targets the cancer cells. No such drugs out yet?
I tell you what, if somebody comes up with something that refined, they'll probably win the Nobel Prize. What I can guarantee you is that the medical community is not asleep. They are all aware of these limitations. They are aware of all these challenges. And I don't think anybody goes to bed any night thinking or feeling like we are done. There is work that is ongoing. We hope it may not happen in our lifetime, but we hope that someday we'll be able to find such targeted therapy in such a way that all the potential side effects, systemic, unwanted side effects of chemotherapy will no longer be a problem. We are not yet there.
Now, one of the things that is killing, we used to say in the United States, but almost now all over the world, because the world has become a global village, is the intake of salt. Now, you said while it's not a causal, what did you say?
Probable. It's thought
it's
to
a
probable risk factor.
Very good. So when I go to do grocery, I pick up something and I'm looking at sodium. I'm looking at the sodium and the sugar content. Is that what euphemistically is called salt? Or when you say salt, is it the cooking salt you are talking about only?
Well, I mean, you're probably interested to know that even the salt, the cooking salt, is equal to the salt that you find on these foods when you buy. It's the same thing, except that they use it as a preservative on the food that you're buying out there, and the other one you're simply adding it at home. Again, unfortunately, we all know salt makes food taste better. All we can say, and this is not the definite risk factors, all we can say and that we can do is that you just take enough. There are some people that when I go to their homes and they give me food, I'm like, I cannot eat this. But I see them, they're adding salt. So people just have different taste levels. All you can do is listen and hear that maybe excessive salt use is putting me at risk. Can I cut down? From wherever you are, cut down. That's all I can say. And by the way, you know,
yes, sir.
High blood pressure. One of the main drivers is what? Salt intake. So when we give you water pills, one of the main things is make you pee out a lot of water, which is driven by sodium loss. So we try to empty you of sodium. So it's not only going to help you for perhaps talking about stomach cancer, but overall health, you will be better.
I have about 2 questions more before we round up on this show. I'd like to tell everybody watching to take out a notebook and a pen, ballpoint pen, or whatever, pencil. Get ready. Dr. Ditah is going to end the show with points, bullet point format, what your take home message this evening should be. So get ready for that. Before my last 2 questions, Dr. Ditah, I'd like to alert people, the viewers, that Dr. Adeline Nukuna will be coming on soon. That will be this week, midweek, to talk about sexual dysfunction, poor erection, premature ejaculation, and why some women just lose interest in sex altogether. So we'll be talking about all those things. You also want to watch. This is tearing down a lot of marriages and relationships. So you want to watch Dr. Adeline Nukuna coming on soon on this platform. Dr. Ditah, when you diagnose somebody with any form of cancer, and today we are talking about stomach cancer, are there things that you tell the person to not eat in the course of the person's treatment?
I think it's important for me to make a disclaimer here, just to say, while I diagnose stomach cancers, I typically will allow our colleagues in oncology to lead on the treatment. I do not specifically prescribe the chemotherapy or things like that. I diagnose you, I get the tissue, I make the diagnosis, I check to make sure perhaps you don't have spread anywhere else. If that's the case, I'll send you to an oncologist who will then work with a surgeon to determine what the best treatment for you is.
And the reason I ask this question is because, again, visiting cancer patients, I have friends and relatives, some of whom have had these cancers. They're told to not eat dairy products, take dairy products, I think meat or some other. So that's why I ask if there are certain regimens, food regimens they should stay on while they are being treated for cancer.
For sure. I mean, we spoke about some of the risk factors, even though not proven. If I got diagnosed with for example, early stage cancer and I got treated, I'll certainly be scared. And even though some of these things are not completely proven, it doesn't hurt to limit, for example, excessive salt use. If I am obese, get out there, exercise, and lose weight. If it means I eat more fruits, which they say they are protective, eat more vegetables. If you're smoking, stop smoking. If you're drinking too much alcohol, they are thinking it may possibly be related. Cut down. But in terms of food, they are not, typically these are patients who already face problems with malnutrition. There are patients that by the time they even come for treatment, you cannot treat them because of their nutritional status. So there are very few, I cannot even think of one immediately, cancers that during treatment, you will be asked not to eat because these patients typically are malnourished. And with chemotherapy, it's going to add a significant challenge to this patient to the point where if you were to limit their nutrition by asking, don't eat this and that, they're going to be in real trouble. So I get this question a lot. Colon cancer, stomach cancer, liver cancer. And the first question they ask me, is there something I should avoid? And I tell them, eat whatever thing you like to eat. Enjoy it. I don't limit. And I don't think that you will find a lot of cancers or you'll find a lot of physicians who limit what their patients eat when they have cancer. Because in fact, we are struggling to maintain their nutritional status.
Dr. Ditah, it's true that we're talking about stomach cancer this evening, but there's something that especially we human beings like to consume a lot. That's alcohol. Are there cancers that are directly, not probable, directly linked to alcohol? I know we're talking about stomach cancer, but lots of people are watching this show, and we're going to rebroadcast this show a lot in watch parties at different times of the day to meet different audiences. Now, are there some cancers that are directly linked to the consumption of alcohol? If yes, which ones?
There are certainly cancers that are associated with excessive use of alcohol. For example, we just talked about stomach cancer. Alcohol is linked. Is it causal? We don't know. We don't think so. We don't have the evidence to say it caused it. I said H. pylori, we have the evidence, we know the mechanism, it causes stomach cancer. We said smoking, we know the mechanism, we know the evidence, it causes lung cancer. But in terms of alcohol, we do not have that one, I do not know of that one cancer where we know that if you consume alcohol, we know the mechanism by which you can get to have the cancer. We do not. But we know alcohol has been associated or linked to a handful of cancers. You are looking at cancers of the ENT area. The ENT area is the ear, nose, throat. So oral, neck, and throat cancer. Of course, smoking is the strongest factor. But we also know that smoking plus alcohol, the risk is even higher. So they actually think that they may have what people call a synergistic effect. Synergy means if I have one factor, it may take me 10 years to develop a cancer. But if I have this factor and this factor, instead of the 10 years, it will take me 6. So this factor is permissive or works in synergy with this one to make the outcome worse. So throat and neck cancer, stomach cancer, pancreatic cancer, these have all been related to alcohol use. But the evidence is not as strong as the evidence that we make for smoking and lung cancer or H. pylori infection and stomach cancer. No.
Doctor, before I let you off the hook, before I let you go, I know Minnesota is very cold. You probably want to go under your blanket now. What is the take-home message? What should people take home after listening to you talk so clinically on stomach cancer?
Yeah, again, I will start by really, again, I appreciate the work you're doing for our communities. I think this is very important. I will invite your guests to share this presentation. You don't know who you may be helping. I'm sure you've heard me say it several times that I cannot wait for the day I go back to Cameroon, because I really look forward to the day I'll be able to help some of the people whom I think have a lot of need, unmet needs when it comes to this kind of problems. So to come back to stomach cancer, the first point I want to make is that stomach cancer is the second leading cause of cancer deaths in the whole world. This topic is important because we all have a stomach. And since we all have a stomach, we are all in a position where we can get stomach cancer. We have discussed some of the risk factors of stomach cancer. And we have said the one strongest definite factor that we know is related to stomach cancer is H. pylori infection. This is a bacteria. The good news is that if this bacteria is diagnosed, you can be treated completely. Unfortunately, the symptoms are often not sitting out there shouting, or those that push you to go to the hospital. But if you come from the regions that I describe as high risk regions for H. pylori infection, which include anyone of African descent, people from Far East Asia, please have a low threshold for going to your physician to get checked out for H. pylori infection. The testing is easy. It's a stool test, most often than not. That leads to the diagnosis. There are other ways of testing, like a breath test. Or if you happen to have an upper endoscopy, we take tissue. And once we make the diagnosis, treatment is 10 to 14 days. Again, because stomach cancer symptoms are very quiescent, there is very little we can do. But if you have any sign, any symptom that occurs that you did not have before, that you're worried about, and you came from any of those regions I cited, again, the threshold to go and see your physician should be very low. Unfortunately, we do not have a lot of good therapeutic options, driven by the fact that by the time people are diagnosed, disease is late. So all we can do, or all I can say on here is, any factor that you can modify, and the modifiable factors, among others, include smoking, fighting your weight, and if you consume excessive amounts of alcohol, please decrease them. Encourage healthy eating habits. Eat fruits, eat vegetables. Those are thought to be helpful. If you can drink green tea, do it. They also think it may be helpful. Otherwise, we do not, it is at this point, screening for stomach cancer is thought to be not to be cost effective. So we are not close to any guidelines where they will say, please, every person, just like we do screening colonoscopies, should get screening for stomach cancer. So again, Divine, I will stop it at that. And just thank you and thank your audience, everyone who was here listening. And hope it was helpful. And if people have questions, they can continue to pose them and I will try to address them.
Exactly. Even though Dr. Ditah will be getting off the show in a moment, don't go away yet, Doctor. If you have any questions whatsoever about stomach cancer, please post them. Dr. Ditah is watching in the green room. He will pick up the questions as he has time. He is always very busy in the hospital in Minnesota. Again, I want to thank you, Dr. Ditah. Each time we come knocking at your door, you are coming to share your knowledge. I can also understand why, like one of your classmates in high school, I think that was in Bengui, GHS Bengui, was it Cas Bambili or Bengui?
Cas Bambili.
Cas Bambili. One of Dr. Ditah's classmates in Cas Bambili said, at graduation ceremonies, this gentleman you are watching made them miserable. He grabbed all science prizes. So I'm not surprised that Dr. Ditah has turned out to be one of the best medical doctors in the United States. By the way, Dr. Ditah is among three others that are medical doctors from the same mother. It looks like their mom and dad, they have the genes to only bring forth children that are medical doctors. Otherwise, I don't understand how 4 of you from the same mother are specialized medical doctors. Thank you so much again. My name is Divine Chamokong, but before we go, Dr. Ditah, one of your colleagues, Dr. Adeline Nukuna, will be coming on midweek for a midweek special broadcast to talk on sexual dysfunction, poor erection in men and premature ejaculation and other sexual dysfunctional problems in both men and women. That's going to be also a very exciting show you want to watch. You watching, please, again, I have said it so many times. If your friends have stomachs, your family members have stomachs, your children have stomachs, you better share this information by actually sharing the broadcast. It will go far and wide. I myself, even though I anchor the broadcast, I'll go back and watch it all over. I'll be playing this broadcast in different times of the day in our watch parties at Chat Night Africa Live. And that's probably how we end the show. Thank you again, Dr. Ditah, for coming on, and extend my love to everyone there, friends of Chat Night at Minnesota.
Thank you very much, Divine, and have a good night.
Okay, and we will end as Dr. Ditah exits the stage. We will be ending with this song, this beautiful song by artist with voice. We are ending this broadcast with the song Ebola by artist with one name. You want to not miss the broadcast, which will have as guest Dr. Adeline Nukuna. Will be talking about premature ejaculation, poor erection, and other areas of sexual dysfunction in both men and women. That's how we round off the show, Chat Night Africa.
calling on the whole world to see men.
Thank you
women,
all for
and
watching.
greatness gone down too soon.
Thank you, Dr. Ditah. Artist with one voice. Directed, produced by Peter Ngutayong. Your host is Divine Chamukong. Ebola, come on.
Was silent killer, raging so hard.
Share this video, share this video.
Women and children dying. See the strong man wiped away in West Africa. Ebola was silent killer, raging so hard.
And that has been Chat Night Africa Live.
Women and children dying. See the strong
And thank you, Maros Tangam, and other people who have sponsored this broadcast. For you to see this platform the way it is.
Looking across
If you're a business person, you can come on the show and talk about your business and promote your business on Chat Night Africa Live.
No, we can overcome. So we calling on the world to lend a hand of love. Children die, mothers cry. See the father's son with no more tears to cry.
Chat Night Africa Live from Washington, D.C. metropolitan area.
Is a painful road. Don't step aside. Hear a cry in the land.
Was silent killer.
I want to thank all of you for watching this broadcast. We will again be joining you midweek for another special edition.
Women and children dying.
And my guest will be Dr. Adeline Nukuna. She will be connecting from Delaware, United States. And if you are making a difference where you are, you can inbox me. I would like to take you on Chat Night Africa as guest. Tell your story, motivate people, inspire people. Don't take your story to the grave. Help somebody with your unique story. Yes, that's Chat Night Africa.
Nanya fondali masada ndema andi basi soro jangaru jufu tetanadi nanya fondali masada ndema andi basi soro jangaru jume boni tepo ibola.
And this is Artist with One Voice, led by Peter Ngutayong.
Nye fala moba ye fala biro sungu nye fala Cameroon kende ye fala jangaru jume boni tenko ibola mbadinu jangaru jubaleo dindi nye fala wo mobali ye fala anyambulu di nyoma afrike dino ka ibola kele.
Merci à tout le monde. Thank you for watching. I will be putting this broadcast on different watch parties at Chat Night Africa Live. Share this broadcast, share this broadcast.
In West Africa, women and children dying. See the strong
In
men
case you just joined us, we've been talking about stomach cancer. And my guest has been Dr. Ivo Ditah from Minnesota.
raging so
Chat Night Africa extends greetings to Dr. Eunice Bonmesia, Dr. G.
When you cry, myself, go cry.
Trouble we can meet, we go down one day. We go play love again. Picking and go learn, all things go fine.
Share this broadcast on stomach cancer.
Let we join, we hand for set this sick and there bam go.
Midst of the storm, anticipating better days and being optimistic, still smiling even when the sun is smiling back at us. Cause we know that one day Ebola will leave and the rainbow will come out and dance with us while we don't grieve no more. Say bye-bye to the pain, our homeland will regain. Now help me sing along to the song, Healing from Rain.
As I watched the news, I saw all the land up before his wife.
This is Chat Night Africa Live.
Leaving a woman to be a widow, and I saw a little girl forced to become a teen parent, all because of Ebola. Ebola way.
Okay, thank you so much. I love you. Thank you. Bye bye. Au revoir. Merci à tout le monde. Share this broadcast on stomach cancer. Share it. And this is Bitango Tayon with artist with one voice.
Women and children dying. See the strong man.